Thank you for joining the Prostate and Testicular Preceptorship 2026. I'm Peter Loh, medical oncologist from Hospital Bakar Sultanah Fatimah. I would like to thank the scientific committee for the invitation and to share on this topic, germ cell tumor, first-line chemotherapy and risk-adapted management. Before I start, allow me to share a story. Germ cell tumor represents one of oncology's greatest success story. Before the cisplatin era, advanced testicular cancer was almost universally fatal. In the mid-1970s, Dr. Lawrence transformed the outcome with cisplatin-based combination chemotherapy and turning a disease with 95% mortality rate into one with cure rates exceeding 95%. Lawrence Armstrong, a famous and professional cyclist who won 7 consecutive Tour de France titles from 1999 till 2005, was diagnosed with metastatic testicular cancer at the age of 25 around 1996, and he was successfully cured with this combination chemotherapy regimen. This will be the overview of our discussion today. We will be covering epidemiology and clinical presentation, diagnostic evaluation and staging, management of early and advanced stage in first-line chemotherapy, risk-adapted strategies, and summary. Epidemiology. Germ cell tumors are the commonest cancer affecting young men between age of 18 and 45, with seminoma showing a second peak incidence between 50 and 60 years of age. And despite this, they remain one of the most curable malignancy. Established risk factors for germ cell tumors include family history, testicular cancer, a previous history of germ cell tumor, undescended testes, testicular dysgenesis, and Klinefelter syndrome. Clinical presentation, often patient presents with a painless testicular swelling or mass. Some may experience a dull ache in the lower abdomen, preanal region or scrotum, while acute pain occurs approximately in 10% of cases. Symptoms may also arise from metastatic disease. In addition, paraneoplastic manifestation can occur, including gynecomastia, hyperthyroidism due to beta-HCG production, and as well as rare neurological symptoms such as limbic encephalitis. Diagnostic evaluation of germ cell tumor, often with a suspected testicular mass, often a rapid structured approach should be carried out, which includes a scrotal ultrasound and sending of your tumor markers, which include alpha-fetoprotein, beta-HCG, LDH, and this would help establish both the diagnosis and baseline for response monitoring. We should avoid scrotal biopsy as this is absolutely contraindicated due to the risk of lymphatic disruption and tumor seeding, and definitive management will include a radical inguinal orchidectomy. Post-orchidectomy, histological will help guide us whether we are dealing with a case of pure seminoma or a non-seminomatous germ cell tumor. Clinical presentation, often there are some key differences between seminoma and non-seminomatous germ cell tumor. We all know that alpha-fetoprotein is never elevated in pure seminoma, whereas it can be elevated or normal in non-seminoma. So seminoma generally also tend to be more indolent and highly radiosensitive, with approximately 85% of cases presenting in stage 1. Conversely, non-seminoma display a more aggressive clinical behavior and are not as sensitive to radiation therapy, and only about 50% of cases are caught at stage 1. Seminoma almost always spread through the retroperitoneal lymph nodes prior to spreading to other areas such as liver and lung, bones, and brain. Patients with seminoma may have elevated beta-HCG, and in cases if they have raised alpha-fetoprotein, often we will classify them and treat as per the non-seminomatous germ cell tumor. In terms of residual mass, often we will, the definition states that a mass greater than 3 cm for seminoma, there is a role of performing an FDG PET-CT to evaluate the nature of the mass. As for non-seminoma, the definition of residual mass is 1 cm, and there is no role of doing a FDG PET in non-seminoma residual mass. Diagnostic evaluation, tumor markers. We know that tumor markers must be checked before and after orchidectomy to establish a baseline and help guide follow-up. But mild elevation alone, for example, alpha-fetoprotein or beta-HCG of less than 20 nanogram per ml, should not drive diagnosis and management purely. Beta-HCG and alpha-fetoprotein can be raised in several benign non-testicular malignancy situations, and we all know that LDH is highly non-specific and may be raised in many systemic conditions, including post-GCSF use. Therefore, LDH alone should never be used in isolation for diagnostic or risk stratification, but all markers must be interpreted in the clinical context. Staging. The special progression of testicular cancer is broadly categorized into three clinical stages. Stage 1, often disease is localized and confined to the testis. Stage 2, disease has spread infradiaphragmatically to the regional retroperitoneal lymph nodes. And stage 3, essentially the disease demonstrates distant mass extending to the supradiaphragmatic lymph nodes and visceral organs. The clinical nodal stage is strictly determined by the objective measurement of the largest involved lymph nodes. In clinical decision making, nodal disease often is classified by the distinct size threshold to differentiate between bulky more than 3 cm and non-bulky less than 3 cm status. Staging as per the TNM AJCC 8 edition. Before reviewing the stage grouping, baseline criteria, for example, your TNM, your S should be evaluated. And often serum markers used for risk classification must be drawn post-orchidectomy and represents the upper limit of norm. The N will represents your nodal status, and for stage IS, it will represents a persistently elevated post-orchidectomy serum tumor markers without radiographic evidence of disease, and in this situation, often we will treat them as advanced favorable risk. Early stage seminoma. So seminoma has an excellent prognosis with 90% of cases presenting in stage 1 to 2. In stage 1 disease, radical orchidectomy alone is curative in more than 85%, and active surveillance is preferred when adherence is reliable, as 70 to 96% will not relapse, and salvage therapy remains highly effective with minimal long-term toxicities. Moving on to stage 2, management will depend on nodal burden. In non-bulky stage 2A, often is being treated with adjuvant radiotherapy, which includes the para-aortic plus minus or ipsilateral pelvic nodes with nearly 100% 5-year survival, while stage 2B and C, more bulkier lymph node, will often require systemic chemotherapy, either 3 cycles of BEP or 4 cycles of EP with radiotherapy. Hence, this could avoid a relapse later on. Is there a role of adaptive strategy in stage 1 seminoma? There is currently no strong evidence to mandate a risk-adapted strategy in stage 1 seminoma. Often the standard of care, the preferred option would be active surveillance, and other adjuvant options would include chemotherapy, radiotherapy, and hence adjuvant therapy should primarily be considered based on patients' likelihood, whether they can adhere to a strict and rigorous active surveillance protocol, essentially if they go on for active surveillance rather than risk factor alone. While a formal risk-adapted protocol is not universally mandated, the pooled data, as you can see, essentially suggests that any tumor larger than 4 cm, retinoblastoma involvement, these are independent prognosis factor predicting a higher baseline risk of relapse on surveillance. Even in patients with high risk of relapse, the peculiar thing about germ cell tumor essentially is compared to other solid organ cancer, even in cases of relapse, if you catch them early, there is still a very good chance of still being able to cure them, and OS is still excellent. So this is the NCCN management guidelines for stage 1 seminoma, where you see surveillance is still strongly preferred, especially for PT1 to 3 seminoma patient. And the important note will be the patient must be able to adhere and be reliable and compliant with this strict surveillance protocol as per NCCN guidelines. Moving on to stage 2 seminoma, we know that radiotherapy and chemotherapy are established standard treatment options. And besides that, there is also options which include primary RP-LND and also carboplatin plus radiotherapy in selected cases as a form of de-escalation strategy. And overall outcomes in stage 2 seminomas remains excellent, with 5 years relapse-free survival, approximately 95% of cases. So talking about radiotherapy and chemotherapy in stage 2 seminoma, they are very good standard of care options. We all know that radiotherapy 30 to 36 gray is a durable standard of care options, particularly in limited nodal disease. Chemo is also a good option in this group of patients with 3 cycles of BEP or 4 cycles of EP. Both modalities provide excellent outcomes with 5 years relapse-free survival rates approximately 95%. What about RP primary RP-LND. Essentially, historically, we know that stage 2 seminoma is being managed with radiotherapy or chemotherapy, but RP-LND is increasingly utilized in stage 2 seminoma to optimize survivorship and minimize disease burden. We know the predictable lymphatic spread seminoma often follows the nodal spread, where often it's reliable sequential pattern of nodal mets, where in fact most of the recurrence will be at the retroperitoneal region, and hence RPLND would be an effective strategy not only in local regional control. It helps us also to mitigate long-term toxicities which involves chemotherapy and radiotherapy, things like cardiovascular disease, secondary malignancies, long-term radiotherapy side effects. Essentially, these group of patients are often young. We also know that RPLND is an established oncological effective approach with low morbidity in non-seminal germ cell tumor, and serving as a strong clinical precedence for its application now in stage 2 seminoma. On your left, essentially this is historical. It demonstrated a substantial vertical surgical line of a conventional RPLND, where you see the scar transverse the entire abdomen, represents physical impact, prolonged healing time, and classic with this classic open retroperitoneal clearance. On your right, essentially this is a more modern, minimal invasive RPLND, displaying an excellent cosmetic outcomes with barely visible incision, and illustrates the reduced tissue trauma, minimized pain, and accelerated recovery times. And this is being delivered by contemporary surgical platforms. What about the data behind primary RPLND in seminoma? So data subsets in this table essentially summarizes the paradigm shift from clinical evidence from three landmark prospective phase 2 study, which includes the SAMS, Primitas, and Cotrimis. These trials evaluate the efficacy, safety, and functional outcomes of primary RPLND as an alternative to first-line chemo RRT for patients with early-stage retroperitoneal metastatic seminoma, clinical stage 2A and 2B. Of course, there are some differences between the trials. For example, the nodal size that are allowed to enroll in each of these trials are different. The maximum number of lymph nodes are also slightly different. However, what we can see is that the data from landmark trials, SAMS, Primitas, and Cotrimis, essentially confirm the modern minimally invasive RPND. Essentially, they help to achieve exceptional local disease control and preserve ejaculatory function, and help spare our patient from long-term systemic toxicities from radiation and also platinum-based chemotherapy. Moving on, essentially, this is a paper that I would like to share. Essentially, the SAKK0110 trial, essentially a prospective single-arm multi-center phase 2 study that evaluates novel de-escalated treatment strategy for patients with early-stage metastatic testicular seminoma. Essentially, in this cohort of 116 patients who are diagnosed with clinical stage 2A and 2B seminoma, rather than utilizing a standard multi-agent systemic chemotherapy, for example, 4 cycles of EP or 3 cycles of PEP, or extensive regional radiation, this trial investigated whether it can be de-escalate and use a sequential low toxicity hybrid approach. So what the investigator did was, patients who are enrolled receive a single cycle of carboplatin AUC7, followed immediately by targeted involved field radiation rather than a large field retroperitoneal radiotherapy. And this combination of single dose carboplatin involved node radiation provides an outstanding effective therapeutic alternative for stage 2A and B seminoma, and this helps to minimize both the volume radiation and also the cumulative dose of chemotherapy, and preserve high cure rate while significantly reduce the risk of acute and long-term treatment-related toxicities. Moving and changing gears to early stage non-seminoma, we know that stage 1 non-seminoma, the aim is still to maintain high cure rate while minimizing long-term treatment toxicities. Treatment selection is guided by relapse risk factor, particularly lymphovascular invasion. Active surveillance is preferred for low-risk patients and helps avoid over-treatment through close monitoring and imaging, with imaging and also tumor markers. Primary RPLND helps to provide definitive pathological staging and excellent local control, avoid chemotherapy in many patients. Adjuvant chemotherapy, 1 cycle BP, this is highly effective, helps to reduce relapse risk in high-risk patients. In stage 2 non-seminoma, this is often guided by the disease burden at the retroperitoneal nodal region. Stage 2A, low volume disease. Primary RP-LND is effective, definitive options, achieving a cure rate of 80-90%. 2B, 2C, bulkier disease. Primary chemotherapy is preferred due to high risk of systemic spread. Standard treatment follows a good risk metastatic protocol with 3 cycles of BP or 4 cycles of EP. Primary RP-LND in bulky 2B and 2C disease has low cure rate and often requires adjuvant chemotherapy. And we know that essentially we would aim to discuss all these cases, especially it involves multidisciplinary approach in the tumor board. The management of stage 1 non-seminomatous germ cell tumor focus on risk stratification and optimize the balance of cure and treatment toxicity, and hence landmark prospective data from the AUO German paper and also Svenotika of Swedish and Norwegian groups established that definitive short course adjuvant chemotherapy 1 cycle in BP in AUO study and risk adaptive surveillance based on the vascular invasion status in Svenotika remains a very attractive options. Moving to NCCN guidelines, essentially the NCCN guidelines establish surveillance as a preferred modality for low-risk stage 1 non-seminoma. And with the presence of lymphovascular invasion, this would dramatically increase your recurrent risk to about 50%, and hence shifting the focus towards a more proactive intervention with 1 cycle of adjuvant BEP. In advanced germ cell tumor, often we stratify them into good, intermediate, or poor risk group based on the primary tumor site, presence of non-pulmonary visceral mass, and post-orchidectomy serum tumor markers level. And hence, we need to take note that based on your IGCCC prognosis group, it will affect your 5 years survival and in terms of PFS and OS. For example, a patient with poor risk, your 5 years OS was ranges about 48 in the original IGCCC survival estimate. However, in the updated IGCCC group, your 5 years OS for poor risk would be 67%. And we know that stratifying them according to IGCC prognosis group will also help in terms of deciding on systemic therapy. Essentially, for patients with good risk, often the go-to regimen will be 3 cycles of BP or 4 cycles of EP. Intermediate and poor risk, it will be 4 cycles of BP or 4 cycles of VIP. Summarizing the treatment summary for both seminoma and non-seminoma, essentially early stage seminoma 1A to 2A, often managed. So essentially for stage 1 seminoma, essentially the management primarily will be active surveillance and inpatient. With 2A, more localized disease, often we will go for something more local, regional, for example, adjuvant radiotherapy or primary RP-LND. Often the other options will include chemotherapy. And in patients with more advanced disease, we will essentially stratify them into good risk, intermediate risk, and give them the appropriate chemotherapy regimen. For a non-seminoma in the early stage, often we will stratify them whether they have any high-risk factor, for example, lymphovascular invasion. In patients with high-risk features, often in non-seminoma stage 1, we would recommend adjuvant 1 cycle PEP. In patients without any risk factor, active surveillance would be appropriate if they are able to comply with a strict surveillance protocol. And again, for advanced disease, for non-seminomatous germ cell tumor, we again applies the good risk, intermediate risk, and poor risk category, and will treat them according to their risk status. So these are standard first-line chemotherapy regimens for germ cell tumor, often structured around a universal 21-day cycle length and sharing baseline backbone of cisplatin and etoposide, often being administered daily on day 1 through day 5. This foundational framework is delivered either as a 4-cycle doublet, supplemented with weekly bleomycin for 3 to 4 cycles, or paired with daily ifosfamide for 4 cycles in a VIP regimen. Before initiating a bleomycin-containing regimen, a clinician should carefully assess risk factor for pulmonary toxicity, which includes advanced age, impaired renal function, significant underlying disease, for example, COPD, heavy smoking history, primary mediastinal non-segmental germ cell tumor, and in such high-risk patients, bleomycin is often omitted, and alternative regimens, for example, VIP, are to be considered, and aim is to reduce pulmonary toxicity while maintaining high cure rate. Because testicular tumor, germ cell tumor are exceptionally curable, and they have high cure rate, the clinical focus now heavily depends on survival and also how can we reduce chemotherapy toxicities. This data set outlines the dual burden of treatment, both in the early setting where we are aiming to reduce our chemotoxicity. We are also cognizant about the long-term potential side effect as all these patients are young, they have a long runway in front of them, and how can we improve survivorship and to reduce side effects from systemic therapy or radiation, which often includes neurocognitive, psychological, ototoxicity, cardiopulmonary complications, secondary malignancy, renal muscular impairment, reproductive endocrine dysfunction, and also late effects of pelvic radiation. So my final slide, testicular germ cell tumors are among the most curable solid organ malignancy, with management guided by the IGCCC risk classification and risk adaptive strategies aim to optimize treatment intensity while avoiding overtreatment. Most patients present with early stage disease, while advanced disease remains highly responsive to a cisplatin-based chemotherapy as the cornerstone systemic treatment. Modern management often aims to balance excellent cure rates with minimization of long-term toxicities, and this would help improve outstanding long-term outcomes. Thank you for your attention. My email is provided for any questions for further discussion. Thank you so much.